afternoon, doctors and my fellow colleagues, and welcome to our presentation, which will be about the valvular heart disease and the latest guidelines for the management of patients with valvular heart disease. It will be presented by me, Wissam Fadel, and Nadia Al-Fitouri. The objectives we intend to cover in our presentation include a brief introduction to valvular heart diseases, its epidemiology, class of recommendation and level of evidence, and then the updates for the guidelines for the management of valvular heart disease and the importance of these guidelines. We'll begin with valvular heart disease. As we all know, it is a group of disorders characterized by damage to or a defect in one of the four heart valves, which are the mitral, aortic, tricuspid, or the pulmonary. The defect leads to valve failure or dysfunction, which can result in diminishing the heart functionally, though the particular consequences and the complications depend entirely on the type and the severity of the disease. The term valvular heart disease covers a large number of disorders that could affect the valves, but the ones that are more common and the ones that we're focused on today include the aortic and mitral valve disorders, or as cardiologists refer to, the left-sided heart valves disorders. They include the aortic valve regurgitation or stenosis and the mitral valve regurgitation or stenosis. As well, next is the pulmonary and tricuspid valve disorders, or the right side heart valve disorders. They include the pulmonary valve regurgitation or stenosis and the tricuspid valve regurgitation or stenosis. Another group of very important disorders that affect the valves include the inflammatory disorders. They include infective endocarditis and rheumatic fever. Why are we interested in the management of valvular heart disease? Well, because it does affect a considerable percent of the population. As this graph shows here, around 14% of the population above the age of 75 are diagnosed with a valve disorder. If we focus on the more common ones, like the mitral valve diseases, it affects around 8% of the population between the age of 65 and 74, and around 10% of the population above the age of 75. And the aortic valve diseases, the common form of diseases as well, affects around 2% of the population between the age of 65 and 74, and around 4% of the population above the age of 75. Knowing these numbers, we understand now that the burden of the valvular heart disease is heavy on the community, and its management should be taken seriously. And for that, and since 1980, the American College of Cardiology, or the ACC, and the American Heart Association, or the AHA, have translated scientific evidence into clinical practice guidelines with recommendations to improve the cardiovascular health care regarding valvular heart diseases. These guidelines, which are based on systematic methods to evaluate and classify evidence, provide a cornerstone for quality of the cardiovascular care. These guidelines are intended to provide recommendations applicable to patients with or at high risk of developing cardiovascular disease. They're also intended to define practice meeting the needs of patients in most, but not all circumstances. However, these guidelines should not replace clinical judgment. Now, to ensure that these guideline recommendations remain up to date, they are reviewed on an ongoing basis, with full guideline revisions in an approximately 6-year cycle. The 2014 ACC and AHA guideline for the management of patients with VHD was focused on the diagnosis and the management of adults with VHD. However, as the field is rapidly progressing with new knowledge of the natural history of patients with valve diseases, and since several randomized control trials have been published, particularly with regard to the outcomes of interventions, major areas have changed, including indications for surgical management for patients with mitral regurgitation, as well as indications for transcatheter aortic valve replacement. And for that, the new and modified recommendations for each clinical section is included in the 2017 focus update of the 2014 ACC and AHA guideline for the management of patients with VHD, which will be discussed later on with Nadia. But how are these guidelines stated? They are stated on the basis of two parameters, which are class of recommendation and level of evidence. What is class of recommendation? To start with, it indicates the strength of the recommendation by estimating the magnitude and the certainty of the benefit in proportion to the risk. We'll go over the class of recommendations. There are 5. We'll start with class 1, where the benefit is 3 times higher than the risk. When writing recommendations for Class 1, we use phrases as is recommended, is indicated or useful, or should be performed. And when comparing effectiveness for choosing treatment strategies, we use is recommended or should be chosen. While for Class 2A, where risk is almost 2 times higher than the is almost 2 times higher than the risk, writing recommendations, we'll use phrases as is reasonable or can be useful or effective. And for comparing effectiveness, especially for choosing treatment strategies, we use probably recommended or it is reasonable. While in Class 2B, where benefit is slightly higher than risk or almost equal to risk, we use phrases as may or might be reasonable or may or might be considered when writing recommendations, or phrases as usefulness or effectiveness is unknown or unclear. For Class 3, moderate, where benefit is equal to the risk, writing recommendations for Class 3 will use phrases as it is not recommended or it is not indicated or it's not useful or should not be performed. While for Class 3 strong, where risk is higher than the benefit, we'll use phrases as potentially harmful, causes harm associated with a high % of morbidity or mortality, or should not be performed. The next parameter that we've mentioned is the level of evidence, which rates the quality of scientific evidence that supports the intervention on the basis of the type, quantity, and consistency of data from clinical trials and other sources. We'll go through the levels, starting with level A, where evidence are of high quality and they're acquired from more than one randomized controlled trial, or meta-analysis of high-quality RCTs, or one or more RCTs corroborated by high-quality registry studies. While level B randomized, they're moderate quality evidence acquired from one or more RCTs, or meta-analysis of moderate quality RCTs. While level B non-randomized, their evidence acquired from moderate quality evidence acquired from one or more well-designed non-randomized studies, or meta-analysis of those well-executed non-randomized studies. While level C of limited data, evidence are acquired from randomized or non-randomized observational or registry studies with limitations of design or execution, or meta-analysis of these studies, or physiological or mechanistic studies in human subjects. While level C, expert opinion, evidence are acquired from expert opinion based on clinical experience. Now, understanding the class of recommendation and level of evidence will help us understand the guidelines that will be presented next with Nadia.
This brings us to the second part of today's presentation. We will discuss the modified guidelines for the management of aortic stenosis and mitral regurgitation according to the American Heart Association and the 2017 updated guidelines. We will cover aortic stenosis treatment, including surgical aortic valve replacement and transcatheter aortic valve replacement, and then we'll highlight new guidelines regarding mitral regurgitation, chronic primary and secondary intervention. As we know, aortic stenosis is the obstruction of blood flow across the aortic valve, and it is a chronic progressive disease that affects elderly mostly. It produces obstruction of the left ventricular stroke volume, which may lead to symptoms such as chest pain, breathlessness, syncope, and fatigue. However, some patients may be asymptomatic. It may be due to either a degenerative calcific aortic valve or stenosis of a congenitally bicuspid valve, or may be due to rheumatic aortic stenosis. First of all, surgical aortic valve replacement. This is a class 1 recommendation, and this is recommended in symptomatic and asymptomatic patients who meet an indication for aortic valve replacement and who the surgical risk is low or intermediate. The level of evidence has been updated from A to B and R. Prior recommendations did not take into consideration the symptomatic status of the patients, whereas now both symptomatic and asymptomatic patients are encompassed in these guidelines. Aortic valve replacement is beneficial. It provides survival benefit and also improvement of symptoms, as well as improvement of left ventricular function in these patients. And the outcome in both patients, whether symptomatic and asymptomatic, after surgery is excellent. Whether surgical aortic valve replacement or transcatheter aortic valve replacement is used, it is recommended both for symptomatic patients who are both at high risk of high surgical risk, and the choice depends on patient-specific procedural risks, also the patient's choice and preferences. the class of recommendation has been updated from class 2A to class 1, and the level of evidence has been updated from B to A. After long-term follow-ups and also additional random control trials, transcatheter aortic valve replacement has shown to be equivalent to surgical aortic valve replacement in this set of patients. Transcatheter aortic valve replacement is recommended for symptomatic patients who have a prohibitive risk for surgical AVR. The class of recommendation is class 1, and the level of evidence has been updated from B to A after random controlled studies and also additional observational studies. It's shown that there is a benefit for transcatheter aortic valve replacement in patients who were previously deemed inoperable. There was an improvement in patient symptoms and also a reduction in patient rehospitalization. Transcatheter aortic valve replacement may also be considered in patients who have an intermediate surgical risk. Again, the decision whether to perform transcatheter aortic valve replacement or surgical depends on multiple factors such as patient-specific risks, also values and preference. The class of recommendation is class 2A and the level of evidence is BR in this case. This slide summarizes the guidelines for the management of severe aortic stenosis. As you can see, patients who have a low surgical risk are recommended for surgical aortic valve replacement, a class 1 recommendation, and patients with intermediate surgical risk are recommended either for surgical or transcatheter aortic valve replacement. Patients with high surgical risk may undergo both, and the new guidelines suggest that patients with prohibitive surgical risk may go under transcatheter aortic valve replacement. The second part of this presentation will be on mitral regurgitation. It is defined as an abnormal reversible flow of blood from the left ventricle into the left atrium, and this may occur due to any disruption of the mitral valve apparatus. The most common etiologies include mitral valve prolapse, rheumatic heart disease, infective endocarditis, annular calcification, cardiomyopathies, and ischemic heart disease. The new guideline regarding chronic primary mitral regurgitation is that mitral valve surgery is now reasonable for asymptomatic patients with chronic severe primary mitral regurgitation. This is the class of recommendation is class 2A and the level of evidence is CLD. Patients who have a preserved left ventricular function of greater than 60% left ventricular ejection fraction or less than 40 millimeters left ventricular ejection systolic diameter could be considered for mitral valve replacement. New research has shown that there is benefit for these patients and also that the left ventricular systolic function may return to normal and also the size may return to normal in this case. In regards to chronic secondary mitral regurgitation, guidelines have now been changed. Patients who have mitral regurgitation due to ischemic heart disease or heart failure, the usefulness of mitral valve repair is now uncertain. The level of evidence has been updated from C to BR. The 2014 recommendations supported mitral valve repair in this group of patients. However, new trials have shown that there's no clinical benefit of mitral repair in this group of population, and also there's an increase in post-operative risks, post-operative complications. In summary, guideline recommended management is effective only when followed by both the healthcare providers and patients. And adherence to these recommendations can be enhanced by sharing decision-making between healthcare and patients and also involving patients in their selecting intervention based on their individual values and preferences. Comorbidities and other conditions need to be taken into consideration when deciding which procedure is suitable. However, although these guidelines are in place, they should not replace the clinician's clinical judgment. And these guidelines are focused on medical practice in the United States. However, with these guidelines, developing these guidelines in collaboration with other organizations, they may have a global impact in changing and managing valvular heart disease. Thank you. And these are our references. And for further reading, we suggest to review the 2014 and 2017 American Heart Association guidelines. Thank you.